you can hear about it in the newspaper, you can read about it in a journal article, but when you're actually talking to somebody about their unique journey, it's incredibly eye-opening. There's just so few options out there for treatment, and if we can be one option for one type of person or at a certain person's step of their journey to recovery, like that is our dream.
Hello, and welcome to the Future Psychiatry Podcast. I am your host, Dr. Bassi. I'm a physician and biomedical engineer passionate about tech and mental health. I created this podcast to try to bridge the divide between the tech world and the many clinicians out there who are interested in tech. We talk about novel ideas, technical challenges, and future directions. Additional resources and a full transcript can be found on our website, telepsychealth.com, then click podcasts in the top right corner of the screen. New episodes are released every Monday. As we are just starting off, I would greatly appreciate if you subscribe to the show. Or, even better, what would help us the most is if you share it with your friend group on social media. You never know if there's someone out there who'd benefit from this information, or have a new idea that sprouts the next innovation in mental health. I hope you enjoy listening to the show. Thanks a lot. Today we're speaking with Dr. Scott Burwell, who's the founder of Neurotype. Neurotype is a portable brain sensing tool that uses EEG to support people in recovery and those who struggle with substance use disorders. So before we start talking about Neurotype, let's just hear a little bit about your background and how you got interested in this.
Yeah, thank you so much, Dr. Bassi, for having me. So I got interested in substance use disorders. I think going back to, my family owned a liquor store when I was growing up. And so I worked there for many years and have a lot of experience working from behind the counter. One thing that always kind of interested me about substance use disorders is how, some people can, have all the risk vulnerabilities, have access to the drugs and alcohol and not have any problems. And other people can have the same, experiences or even less vulnerability factors working against them and, end up with substance use disorders, addictions, etc. And so,
It is quite confusing.
It's very confusing. And, that conundrum kind of led me to study psychology in undergraduate at the University of Minnesota. And then eventually I went into graduate school studying the genetics underlying substance use disorders and the physiology that stems from those genetics, right? And so, how come substance use disorders run in families? What do those risk factors look like in childhood? Is your brain were you born with a brain that puts you in a vulnerability state? Or is it, your environment that plays into those things? And so I really, unpacked a lot of those things in my dissertation and studying brain physiology. And it's just really an interesting, tough nut to crack, though, for psychologists, for neuroscientists, for clinicians all around. And so that's kind of how I got into this field.
And that's one reason why I wanted you as a guest on the show, because of my background in addiction. I don't often hear of these innovations that involve and incorporate physiology and EEG into the treatment plan. So I think this is a really cool thing you're working on. And I think throughout the interview, we'll get sequentially more and more detailed in how it's all working. So just kind of starting off, when psychiatrists think of EEG, they probably think back of their neurology rotation back in med school when they were working on an epilepsy unit. And I actually did a couple of research projects on EEG back in the day, 2006, 2007. And I know it could be messy, it could be cumbersome, very time consuming, and difficult to apply to a clinical setting from that research setting. So tell us a little bit about the broader landscape of EEG and how is it being applied in psychiatry these days, and what is Neurotype hoping to change about that?
Yeah, absolutely. So you're totally correct. The only way that EEG is typically used in a healthcare setting today, and the only way that it's reimbursed and regulated, is for very neurological conditions. So, stroke or seizures or, epilepsy or other brain disorders that have been around for ages. And EEG itself, as a technology, is really old. It was one of the first ways that people could study the brain and in the live human being, way back to like 1910 or 1920 in that era. And it's come a long way since. The stuff that's still used in hospitals today is fairly cumbersome. It's designed for neurology settings. It's designed for people that work with those devices. But in the past 10 years or so, people have made EEG much more accessible to lay users. So again, electroencephalogram, EEG, it collects the electrophysiology that's generated by your brain, the currents that happen because neurochemicals are shifting their places inside and outside of neurons. And that's a really small, tiny signal to record from on top of your head. Because you've got muscles that are in the way that generate also these kinds of noises. You've got your eyes that are moving, you got people moving, and these things can all cause noises. And what we've been able to do in the past 10 years or so is develop portable electroencephalogram that can get a pretty good read on that really tiny brain signal that's being generated, beneath your skull. In diverse places outside while somebody's moving, all these sorts of things. And what we're trying to do is we're trying to take that neurology EEG that's just been limited to a really limited setting, and we're just trying to step it outside of the neurology clinic into a doctor's office or a waiting room or someplace that's not too far out beyond the reaches of where it is currently, and make that accessible for the people that treat addictions.
So I know that on your guys' website you talk about brain reactivity, and I think that's
Yep.
a phrase that can really help a lot of patients in the addiction world, because I think when they think of their reactivity and impulse control, they think of people, places, things that they that are surrounding them. They don't
Hmm.
necessarily always think of the biologic reasons for their poor impulse control, even though we know TBI and other executive dysfunction elements can contribute to that. I think seeing it in a device is a totally different um, a way of approaching it, a way of seeing it, and how it changes throughout the day or months. Tell us a little bit about how that phrase translates to actual data in the EEG world.
Yeah, absolutely. So as you say, people, places, and things can trigger a person to crave or to eventually use the substance that they might be, addicted to, for instance. And when we show people, so our platform right now, we use portable EEG headsets, and we place that on somebody's head while where they're shown a bunch of slides of pictures. Some of those pictures are going to be like puppy dogs and chocolate cake, really exciting things like, adventure sports. Some of those things are boring things like office supplies, pens and pencils. And then some of those things are drug paraphernalia or people using drugs or places where drugs tend to be used. And for a person with an addiction, for instance, an opioid use disorder, let's say somebody has developed a dependence on pain pill medication. If they see a pill bottle in that array of pictures, their brain is going to produce what's called an event-related potential or brain response to the presentation of that picture that is much like that of the chocolate cake and puppy dogs and adventure
Something
sports.
totally involuntary that they can't control, correct?
Exactly, and it's almost pre-conscious. I mean, you're probably aware of it on some level, but it's to a level of it's kind of riding under the radar,
Right.
and so we can monitor that, multiple times, during the course of a recovery, or multiple times, during the course of a day, even for a person.
And
Um,
what's the time frame that the ERP actually happens after the stimulus?
it happens within, so the brain response itself starts within 300 milliseconds or about a third of 1 second, right? So it's instantaneous, it's involuntary, like you
Wow.
say. And so it's unlike other things where, you might be able to trick a machine by controlling your breathing, or you might be able to trick a machine by like thinking of something else. It happens before you're able to sort of intercept that thing and stop it from
Right. That's
unfolding.
incredible. Because in med school, I remember when I was working with addiction fellows, they were talking about how we were in the inpatient unit, and even putting a tourniquet on somebody or getting Benadryl or even putting an IV in them can almost trigger this feeling of a high in the patient. And
Yeah.
I just found that to be so fascinating. So it's not even the drug itself, it's all of this, the sequence of events leading up to it. And I think
Uh-huh.
that's what a lot of patients need to kind of understand in terms of trying to inspect the relapse itself, because it's probably a sequence of a number of different stimuli that
Yep.
they experienced over the, preceding hours that got them into that mindset of
Yeah.
wanting to relapse.
Funny you mentioned it. We talked to somebody, a person that's in sustained recovery for opioid use disorder, and they actually didn't keep spoons, like dining spoons, in their house because it reminded them of their drug preparation, their heroin preparation routine. And they knew that, if they saw these certain dining spoons, it would kind of put them on this thought pattern or this behavioral pattern that led them to eventual use. And our goal is to really not like teach everyone to take away all the spoons or anything like that,
Right.
right? We don't want that because I don't think that's adaptive or healthy. But make people aware of that so that clinics, clinicians, therapies can target those things more effectively and monitor those things throughout recovery.
That's really interesting. Something that people should kind of know that other people struggle with.
Yeah.
So how does it work? Like, I'm a doctor and I'm working with a patient. Are they going to be wearing the device in the clinic with me and we're going through a therapeutic session, or are they using it outside of the clinic and I'm kind of going over the data with them afterwards?
The way that we currently have it set up, and we are still kind of doing our feasibility testing and working towards clinical trials. But the way that we currently have it set up is that this would be done at a clinic, either in a waiting room or by a technician or even the doctor's office. While the doctor's working on some other like um, reports or things that they need to be filling out for that particular patient. And it's a 5 to 10 minute. We're trying to even get that a little bit lower scan that we just place the headset on the person's head and hand them a tablet. They watch a bunch of pictures, and the report is sent to a cloud. Signal processing and machine learning is applied to that data and then sent back to the clinician. And the clinician can change or make decisions about a person's care plan depending on that data. Eventually, we would like to get to a point where the headsets are affordable enough and durable enough to be taken out of the clinic, thrown in your backpack, right? You can take it home with you. But at the moment, we're kind of trying to keep things still in a healthcare setting, but not necessarily with all the limitations that a neurology clinic has.
Gotcha. And what lobe is this ERP coming from? Like generally speaking, because the way I understand it is that we get the electrical activity on the surface. Unfortunately, we're
Yep.
EEG is very good temporally, but not spatially, and we can't really figure out the exact nucleus that it's coming from. But what lobe are we talking about for
You've
reaction?
done your research. Yeah, that's 100% correct. EEG's great for temporal resolution, very poor for spatial resolution. So you can't make a whole lot of claims regarding where exactly in the brain it's coming from. Fortunately, the brain sensing, the event related potential that we're focused on is generated really broadly. So it's generated by the temporal cortex where there's memories. That's a big memory center of the brain. It's generated by the visual cortex, the occipital lobe, and the parietal lobe that are really there for interpreting sensations, interpreting visual stimuli, these sorts of things. And also, there's some indication that it's being generated by the frontal lobe, based on how attention grabbing it is. These data have been backed up when people have done simultaneous EEG and functional MRI. So functional MRI is looking where blood flows and oxygenated blood flows. And so, using that together, we know that it's generated in a lot of places, but, for our innovation, we're not really focused on exactly, where in the brain, at what sulcus or gyrus it's actually,
Right.
being generated because it's a really difficult thing without knowing how somebody's individual brain folds and how somebody's
Hmm.
skull conductivity is different from the next person's.
Totally. Yep. I remember that was one of the difficulties was mapping, brain mapping, and trying to figure out
Yeah,
where the EEG electrodes go based on
yeah,
landmarks, but the brain can be a little bit different relative to those landmarks. So
absolutely.
I have a patient who comes in a clinic, we do the neurotype, I get the report,
Yep.
and then it's almost like a fingerprint for the brain. It's like doing a blood work, but so like blood work, how much control do they now have where they can incorporate that feedback into their next steps?
Yeah,
Like,
so that's a really good question, and we're open to new ideas for this. But the way that we see it being used is is sort of in an open loop where this is like an A1C for diabetes, right? It's feedback about your disease state that a clinician can use to either prescribe new treatment or take a different treatment approach. Some cognitive behavioral therapy is focused on how you handle your triggers, and so the way that that could be incorporated. There's also exposure therapy or types of mindfulness practice that are focused on seeing or handling triggers in the moment, right? And so if we can make this a just sort of feedback or awareness for the clinician to incorporate, they can use that to target their therapy, but they can also use it to track the effectiveness of their therapy over time. And so it's also kind of like we sometimes liken it to a vital sign or even a Fitbit for or a fitness tracker for your
Right.
brain and in its relation to the addiction that you might have. We are developing digital therapeutic approaches, so brain games that kind of help you sort of identify those triggers and then also train your brain to be less impacted by them. But that is something we're working on in-house and a little bit less um, further along in the pipeline.
Interesting. Yeah, I mean, that sounds like it kind of delves into acceptance and commitment therapy, wherein you have these thoughts and they are attached to some underlying emotion or feeling, and you're trying to disconnect that feeling from the thought itself.
Yeah,
So, it could be anything. Going outside can be a trigger that makes people feel very anxious. And
yep,
then you have to come up with some sort of what's called diffusing strategies, which is a made up word that the founder of acceptance and commitment therapy made up to try to separate the two. And
yep.
that seems like what the digital therapeutic is going to be doing in the future, where they're trying to separate the spoon from the craving, the needle, etc., and just try to make it kind of a neutral stimulus again. Like,
Exactly, yeah, because when we show people without substance use disorders these pictures, the spoon doesn't jump out at them, and so we're trying to get it to that level again, right?
right,
Um, and another thing I just want to point to is that a big goal of ours is to improve the clinician patient interaction. Right now, there's a lot of, substance use disorder treatment field is old, and not a lot of innovation has taken place in the past 20 years there. And we're trying to, you know, take some of the subjective approaches, some of the approaches that for monitoring somebody's disease state that are viewed as sort of punitive, such as like urine drug screens, compliance-based assessments, and these sorts of things. And we're trying to make it look like the rest of medicine, where there are vital signs and measurement-based care is relied upon much more strongly.
totally. I think that will go a long way in reducing stigma too. I used to
Hmm.
give a presentation about the underlying biology of addiction to a family, uh, as a family night. We had family members come in to hear this presentation, and they were kind of blown away about how heritable addiction is and how it's not necessarily um, totally their fault. And it gets into a lot of discussion about,
Yeah,
are you intentionally doing this, or is this something that's ingrained in your mind? And I think anything that will start to build support for the fact that there's an underlying impulse control issue or overreactivity
oh yeah,
would start to alleviate them from saying, okay, I not only need to focus on group therapy and to try to be around the right people who are supportive of me, but also kind of focus on a biological level about
yep.
what these immediate impulses are going on there.
I think you're ringing the right bell because I mean, really, there is so much research that suggests areas where we can improve psychoeducation about the neurobiology of substance use disorders and the genetics of substance use disorders, but very little translation into the clinic has taken place. And I think it's incredibly empowering and motivating and just inspires hope and patience that to know some of these things and that it is a disease and it's like other diseases and should be managed in such ways. So,
Hmm. One thing that I have noticed when I use social media and is that I can do a video that's like very scientific and it's 100% accurate, but if it's not done well creatively, it doesn't
Yeah.
really get that much appeal to it. And same with certain apps. There are apps out there that are created by government entities that are very good, but they look like they're made in 1985 and nobody really downloads them.
Yeah.
And so what kind of challenges do you foresee? I know you have this like very scientific background, but I think what would also set this apart in the field is having something that's very usable, that's user friendly, and that people can like just easily just dive right into and they get immediate feedback and results.
Yep.
Tell me how
Yeah.
you kind of balance the two.
Yeah. We've been one of the things that's really helped us, I think, along the way is just talking to patients and talking to clinicians. The substance use disorder treatment and recovery space is a place where people are want to help other people with addictions, and but you also sort of need to be accepted into you need to work with people and understand what they want more than what you want to show them and push on them, right? I mean,
Right.
so we're really trying to understand what their needs are, what their pain points are, and how this can be most effectively administered to them and attractively administered to them. And so that's a big reason that we're focused on cues, because we know it's an area um, of problem for relapse or recurrence, and so the a focus on cues is also really easy to personalize towards people, and so we're playing around with different ways of personalizing this. So for instance, right now we're just using set kind of static groups of pictures, but it's not beyond the realm of possibility that we could include something from your social media feeds or include
Right. A user
triggers
can
that you
upload a
take.
photo.
Exactly. And so these are really some of the creative places that we want to go. The flip side of that coin is we're trying to build this as a medical device, and that requires regulation from the FDA, and
Standardization.
these sorts of
Yeah.
things are reliant on standardization. So it's a two-way street, and we're trying to figure out where we want to stand on it. And uh but again, I think just getting that user feedback, getting patients and clinicians to tell us what they feel about it and where they see it being useful or problems that they identify with it, is just is very valuable.
Yeah, let's touch on the FDA part just real quickly because I
Hmm.
think it does play a role into where you guys, what direction you're going in. And I've interviewed a few people now, and one person said that they want to get the FDA approval. Obviously, it opens up a different payer pool, payer
Yep.
population. And then another one said, we don't need to. Why even
Yeah.
bother? It's not even necessary. So how are you going to make that decision? How did you make
Yeah.
it?
Um, it's something that we have gone back and forth on. One of the reasons that we decided to move towards FDA is because we've talked to a lot of providers, and many are not comfortable in suggesting something to their patient or even prescribing something to their patient, obviously, unless they have the backing uh, of the FDA. And then on top of that, when we're talking about something that's a medical device and something that, like, especially like an EEG, which is a little bit more involved than just a downloadable phone app or just a some other kind
Right?
of
Mindfulness app, something.
mindfulness trap
Yep.
app or something like that, right? Um, it's it costs money for the headsets. It costs money to maintain these headsets, and it's not like the same prices in neurology, which are really really expensive, but still it costs money. And so clinicians as well as us, we don't want the patients to be paying necessarily out of pocket for all these, especially for community-based clinics or other places that this stuff is that a lot of patients have to go for treatment that don't have a lot of money. And so for something to be reimbursed, uh, it's almost, in talking to insurance companies, it's almost required that such a thing is FDA regulated. Um, so
That
that's
makes sense.
that's been our approach. It could always go that we have a couple versions. One is the regulated version, one's the consumer version, but
Th
we'll
that
see.
makes sense. And I could see why it was so difficult for you guys to make that decision because it is kind of up in the air. It is
Yeah.
nice as a clinician to know, like Alpha Stim, for instance,
Yep.
has FDA approval and I need to prescribe it and there's data there. And it's almost like kind of It takes away maybe some like second guessing about efficacy that the
Yep.
patient might have. It's like, oh, this is actually proved. It must have been vetted very well, versus an app, one of 200 apps that are out
Yeah.
there that are just, out there in the pool. And I'm not really necessarily prescribing it, but more or less suggesting it. They're like,
Yeah.
maybe it's not really that effective. And the placebo effect can be quite broad in our field.
Yeah.
So,
And and as you say this, with all the different apps out there, I mean, there are definitely ethics standards for FDA regulated therapeutics, and not necessarily with anything you download in the App Store, right? And so, uh, people sometimes don't like surveillance, or they don't like, the taste that shared data gives leaves in their mouth. And so,
mhm.
I think also going through an FDA process would help us, gain that kind of credibility as well.
So you mentioned some new features that you want to work on after FDA approval. So it sounds like all hands are on deck for FDA approval at this point. Is that
That's our current approach. We are actively applying for NIH grants. So we already have one NIH grant from the National Institute on Drug Abuse that's focused on validating early validation of this technology in patients with opioid use disorder. We're applying for a follow-on grant to that would be phase 2 that's focused on a clinical trial with our technology, and the outcome of that would ideally would put us in good place for submitting an application to the FDA for regulatory status. And so um, that's our current, all hands on deck, as you put it, approach. But there's so many other fun things that we think of as we move down this pipeline. We talk to people, and it's like, oh, just add this to the to-do list, right?
Yeah, totally. I know it's sometimes like your mind moves faster than the clinical research can
Yeah,
handle with all
definitely.
the new
Yeah.
features and stuff.
Yeah. By the time that we learn something new ourselves, we're like, well, we know that now. What's the next thing we can focus on before? And it's hard to just stay the course and just focus on the thing that's going to get us into the clinics and out the door,
Hmm.
right?
Right. Given everything we said about how it works, have you noticed any misconceptions that clinicians or other engineers or patients have
That's a
about
gr
how it works and what you want to change about those misperceptions?
Yeah, so there's a lot of neurofeedback out there. It's not a new term. And one of the things that we run up against is that prior neurofeedback has relied on something that's called QEEG, or quantitative EEG. And QEEG, well, it has some merits. It's incredibly engaging, and it's fun, and it's easily applied. It doesn't involve looking at pictures. It's basically the state of the EEG sensors when you're just sitting there, and maybe you're practicing mindfulness, or maybe you are interacting with your environment in some other way. It's incredibly easy to bias by things like a person moving or a person scrunching their muscles, like I described earlier.
Hmm.
And this has led it to all sorts of pitfalls in terms of being clinically valid. It doesn't tie well to certain disorders, and certain outcomes, right? And we look like that from the outside, even though our technology is very different from the inside, right? So you put a head sensor on somebody and you give them a tablet, and clinicians immediately think, "Oh, this is like everyone else's neurofeedback," which I know is not been validated. It's failed before in clinics. And so what we're trying to do is really drive home this point that this is a new kind of neurofeedback. This is the next generation neurofeedback that's reliant on event-related potentials, which are not biased in those same ways. A muscle scrunch doesn't screw up your signal.
Hmm.
A person moving doesn't screw up how your brain is responding to pictures on a screen, right? These are very like time-locked, pre-specified brain responses that we can model, and it removes all that noise and all that concern that we have with traditional neurofeedback. And so I think trying to nail this point, with talking to clinicians and talking to patients and showing like, here's something that's going to be equally engaging and equally enjoyable and insightful, but it's also going to have some scientific validity to it and clinical validity to it. That's an important point that I want to drive home, because this reliance on biomarkers from event-related potentials has has just had so much uh, peer-reviewed research that supports it versus QEEG, which has been sort of torn apart in the
Mm,
in the um, in the in the academic space. I don't want to throw the baby out with the bathwater though either. I think there are some definitely good things that come from other types of neurofeedback, but um, we don't want to be just lumped in with everyone else. Is what I'm trying to say.
right. And as you were talking, it kind of made me think about how I mentioned that it was involuntary. And I think that might give somebody the impression that they can't use this data to help them over time. Have you guys looked how the ERP changes over time with therapy? And if there is hope there for somebody actually using this data to actually get better and start to reduce their reactivity levels?
So yeah, so full disclaimer, this has not been in a clinical trial, but just anecdotally, we found in people that remain abstinent for a year that there is a significant, or there's a reduction in the amount of, and this is just a handful of people, mind you,
Mhm.
in the amount of brain reactivity to opioid cues in people that remain abstinent for that year. And this is in line with other research that's been done with people with stimulant use disorder, cocaine use disorder, and that's peer-reviewed, published research. I think in the Journal of the American Journal of Psychiatry, and there's other studies that have shown that this kind of brain response, if it's big, it is indicative or predictive of relapse risk. Um, but these are the sorts of things. These are our targets for the clinical trials that we plan to conduct in the next year or so. Um, but we really like to test this out in people at different stages of recovery. So people early on, people after 6 months of recovery or abstinence, people after 1 year, and then also people like 5 years down the road, people that are sometimes considered recovered, right?
Hmm.
Um, and see how these triggers are monitored in these different populations.
Well, I hope that you guys have an easy time trying to get the clinical trials through the
Yeah,
IRB. It seems like a very
thanks.
low risk procedure to do, a low risk
Yeah,
device, and it has a high upside potential for it. So,
yeah, that's definitely a benefit of EEG. It's
mhm.
non-invasive. It's fairly easy to apply and low risk as far as that goes.
In your journey through this space, what was your biggest surprise, would you say?
Really talking to people, talking to people with addictions, talking to clinicians. Um, there's so many paths for how somebody gets to an addiction clinic, or addiction treatment, or people that don't even make it there, right? People that just develop a substance use disorder, and
Nodding my head forcefully.
yeah, and it's very eye-opening to see it when you're actually just talking to someone. You can hear about it in the newspaper, you can read about it in a journal article, but when you're actually talking to somebody about their unique journey, it's incredibly eye-opening. And so one thing that we have uh, tried to do as we develop this innovation is drive home the point that we um, might not be for every single case. For how multifaceted and how many different ways people get to an addiction, there's a lot of stuff going on. And we're trying to treat or trying to address a fairly small slice of this big pie of all the reasons somebody could have a substance use disorder. And, um, you know, there's there's just so few options out there for treatment, and if we can be one option for one type of person or at a certain person's step of their journey to recovery, like that is our dream. But we don't necessarily want to, we're not trying to say that we are the be all end all of treatment for addictions, because there's a lot of great things out there that people are doing that help people regardless. So
Right. That's a good point and a good disclaimer for the listener. We use these words out of convenience, but they mean a very heterogeneous population of people,
yeah.
and everybody has their own story. And I'm a huge advocate for individualized care and approaching every patient based on their experiences of what worked, what didn't work, what they're interested in, what they have the resources to do moving
Yep.
forward.
Yeah,
Is the
absolutely.
reason that you're targeting the substance use population because the ERP is more consistent and reliable in that population versus, say, anxiety stimuli?
Yeah, it's all about the cues that we can show people. And so in substance use disorders, the cues are very well defined, right? It's drug paraphernalia, it's people
Totally.
injecting, using drugs, et cetera. But, there's not much of a reason that you couldn't apply this to other disorders, other psychopathology, right? Um, Probably the most research that's been done with this kind of showing people pictures and seeing how their brain reacts is been done for affective disorders. So uh, depression, post-traumatic stress disorder, right? People are equally triggered sometimes by, a combat veteran might be triggered by combat-related cues. A person with depression that has something called anhedonia, or like a lack of response to pleasurable situations, has a brain response that's not as big to the pleasurable cues that they're shown, right? And so um, there's obsessive compulsive disorder, all these different things that it could be also applied to. We're really kind of trying to intervene with especially opioid use disorder for how big of a problem it's grown to be, and how just dangerous it really is. I mean, there's I don't, you've probably seen the statistic that over 100,000 people died of drug overdoses last year alone. And that number is almost double from what it was a few years earlier, before the pandemic. And so, this is kind of, we're trying to, put the fire out as fast as we could, or help put that fire out, I should say.
Yeah, so I totally see the potential in this, and I appreciate you kind of laying out the roadmap because I do see there's a number of challenges on your path forward. The FDA approval,
Yeah.
outlining who this is going to be most useful for, to figure out who your target population is, and then figure out how to pair it with uh, treatments, maybe medication or otherwise, to start to actually use the data for meaningful therapeutics,
Yep.
and then individualize it for the patient.
Yeah.
So
It's
it's a really bright future for you.
yeah, there's a lot of work to be done, which is good for us. Keeps us busy, but it's also a little daunting. And we can't do it, I can't do it by myself, and that's why I've got a great team, and we're trying to build this team, but that takes money too, and so we're also applying for grants to build the team, and start to raise capital, et cetera. So it's a
Totally.
journey.
So, but I think 20 years from now, we're going to look back at 2022 and kind of sip some tea and listen to this audio and be like, wow, I mean, it has come such a long way. And where
Yep.
do you see us needing to get in 5 years in order to get there down the road?
Yeah, in 5 years, you can already see this in with digital therapeutics sort of sparking up, but there's just more options that are starting to come into play, which is advantageous, right? There's some new devices, new software devices, new apps and digital therapeutics that are coming on the market. But I think more broadly speaking, a shift towards measurement-based care. So for addictions, right? So measuring how somebody is, a lot of times throughout a given day, or a lot of times throughout their treatment course, and adapting care in such a way that can address maybe vulnerable spots or blind spots. So, for instance, with these triggers, if somebody's not aware of their triggers, or if these triggers, especially evocative to people, but a clinician doesn't know about it, how's the clinician going to intervene with that person? If the person doesn't say anything about it, right? And so if we can measure important biomarkers or important other, sort of self-report kinds of things that patients might have, we can more effectively target certain symptoms or certain vulnerabilities that patients have. And I think, in 5 years, we're going to be a lot better suited to do that. And in 20 years, this space is going to be entirely transformed. I have faith.
That's so cool. Well, Dr. Scott Burwell of Neurotype, I really appreciate you being on the show and talking to us about all of the challenges that you've overcome and where you see things going in the future. If I had money lying around, I think I'd most certainly invest in you guys.
Good
It
to
sounds
know.
like it's going to
Thank you.
be just front and center in how we approach addictions, with obviously a very set population of individuals.
Awesome. Well, thank you, Dr. Bassi. It's been very fun to talk to you, and thanks for
Yeah,
having me on.
thank you so much. As a reminder, if you'd like to support the show, one way you can help us is by subscribing to the channel on YouTube, and leave a comment if you'd like. It'd also mean the world to me if you can share it with your social media network. Maybe there's somebody out there who might be interested in the podcast. Hope to see you next week, next Monday. New episodes are released every Monday morning. Thanks a lot. Take care.